Welcome to Ink and Air channel from OptimalAnesthesia.com. Just a heads up, all the detailed content and evidence-based references for this deep dive will be up on the website starting June 2025.
Good to know.
So today we're digging into a pretty rare but serious thing that can happen after surgery. It's called masseter muscle necrosis.
Right. Necrosis of the chewing muscle.
Exactly. And we're going to look at a specific case where how the patient was positioned during a long operation and, a certain monitoring technique, they kind of seem to interact.
Yeah, it's fascinating how these factors can converge. We're talking about a 50-year-old man here. He was, well, clinically obese, BMI of 35.
Okay.
And he had this really long 8-hour surgery to remove a neurofibroma, lying face down the whole time.
8 hours prone. Wow. And then what happened?
Well, after the surgery, he developed this pretty obvious swelling just on one side of his face, the right side. He was tender.
Okay, let's unpack that. So T6 and L1 neurofibroma resection, 8 hours prone, BMI 35, then boom, unilateral facial swelling post-op. That's definitely not typical.
Not at all. Sets off alarm bells.
So what were the first thoughts? Anesthesia-related complications?
Absolutely. That's where your mind goes first. And they use succinylcholine for intubation, 75 milligrams. So malignant hyperthermia, MH, that's immediately on the differential. Big concern.
Right, MH is always the scary one with succinylcholine. But the classic signs weren't there in this case.
Correct. You look for muscle rigidity, that sudden spike in CO2, hyperthermia. None of that was present.
And the labs. CK, potassium.
All normal, which is pretty reassuring against MH. There was a good study back in, I think, 2010 that really laid out the usual MH picture, and this just didn't fit.
Okay, so MH is off the table. What else? Rhabdomyolysis, maybe? Muscle breakdown from the long surgery?
That was considered too, yeah. Rhabdo can definitely cause muscle swelling and pain, but again, the labs didn't support it. The CK levels were fine.
So ruled out MH, ruled out rhabdo.
Yeah.
What's left?
Well, the spotlight then turns to mechanical pressure, good old-fashioned pressure injury.
Leading to masseter muscle necrosis? The chewing muscle again?
Exactly. It sounds almost too simple, doesn't it? But think about it. 8 hours prone, head in a headrest. Especially for someone with a higher BMI, there's more soft tissue there.
Batting, yeah.
And that masseter muscle can get seriously compressed against the headrest.
And it's that sustained pressure. That's the critical thing. There's like a threshold, isn't there?
Yeah, exactly. Once the pressure on the tissue gets above its perfusion threshold, we think it's around 32 millimeters of mercury, give or take.
Right.
The blood flow just can't keep up. Damage starts.
Okay, so walk us through that. What happens inside the muscle when the blood flow is cut off for that long?
Well, it's a cascade, really. First, no oxygen gets in. That's ischemia leading to hypoxia. The cells try to work without oxygen, anaerobic glycolysis, but that's inefficient and builds up lactic acid.
Okay. Acid buildup. Not good.
Not good at all. Then the cell's energy currency, ATP, gets depleted. Without energy, the cell membranes get leaky and calcium floods into the cells.
Ah, the calcium influx. That's often bad news in cell injury, right?
Definitely. That excess calcium activates all sorts of nasty enzymes that basically chew up the cell from the inside out. Proteins, lipids, the works. Leads straight to myocyte necrosis, muscle cell death.
And it doesn't stop there.
No, because the pressure also squashes the veins, so blood can't get out easily either. Get venous congestion, more waste buildup, more acidosis, and inflammation kicks in. It's a vicious cycle. Studies looking at pressure ulcers and deep tissue injury detailed this exact process.
Makes sense. A really nasty local environment develops.
Precisely.
Okay, but this case had another wrinkle, didn't it? The use of motor evoked potentials, MEPs.
Ah, yes, MEPs, used for monitoring the spinal cord function during the surgery.
How do they factor in?
Well, MEPs work by electrically stimulating the brain and then measuring the muscle responses down the body. It checks the integrity of the motor pathways in the spinal cord. Okay.
But that electrical stimulation can cause muscles to contract, unintended contractions sometimes, and the masseter muscle. It's definitely one that can get stimulated, especially if you're trying to keep the neuromuscular blockade, the paralysis kind of light to get good MEP signals.
Oh, I see. So you've got this muscle, the masseter, that's already being squashed by pressure.
Right, blood flow already compromised.
And then that's also being made to contract, maybe just subtly, by the MEPs.
Exactly. It's like a perfect storm almost, a synergistic effect.
Yeah.
The pressure causes ischemia, making the muscle vulnerable.
Uh-huh.
Then the MEP-induced activity increases the muscle's metabolic demand. It needs more oxygen and energy right when it's getting less. Plus, muscle activity generates heat.
So you're adding metabolic stress and heat, to an already oxygen-starved compressed muscle.
You got it. That combination can really accelerate the ischemic damage, pushing it over the edge into necrosis much faster or more severely than pressure alone might have.
Wow, that really complicates the picture. It raises questions about balancing monitoring needs with tissue safety. It absolutely does.
So given this risk, what can the anesthesia team actually do to prevent it? I mean, it sounds like it's not strictly an anesthetic complication like MH, but the anesthesiologist is right there managing things.
Oh, absolutely. Prevention is key, and the anesthesiologist is central. First off, equipment matters. Using the right kind of support for the head and face.
Like gel pads, special pillows.
Exactly. Things designed to distribute the pressure to avoid concentrating it right on the masseter or other vulnerable spots. Specialized prone face pillows can make a big difference.
Makes sense.
Yeah.
What else? Just watching the position.
Vigilant monitoring, absolutely, throughout the entire case. Making sure the head isn't tilted funny, that the pressure seems evenly distributed, that the eyes are clear.
And checking periodically. You can't just position and forget for 8 hours.
No way. Periodic pressure offloading is crucial. When it's safe from a surgical standpoint, just slightly adjusting the head position, even in brief moments, can allow some reperfusion. Lift and reset, if possible.
Little breaks for the tissue.
Kind of, yeah. And maintaining good blood pressure is important too. Keeping the mean arterial pressure, the MAP, generally above 65 mmHg, helps ensure blood can actually get to those compressed tissues. Good systemic perfusion helps fight local pressure effects.
Right. Basic physiology, but critical here.
Very critical. There was work back in the 90s highlighting ischemic myopathy risks in prone cases, stressing these very points.
Okay, so prevention is multifaceted. But let's say, despite best efforts, it still happens, or you suspect it. What are the post-op warning signs?
The biggest red flag, as in this case, is that unilateral facial swelling after a long prone surgery. Especially if MEPs were used, and maybe if the patient is obese, that should definitely trigger suspicion.
And you have to differentiate it from other things.
Definitely. Could it just be positional edema, an allergic reaction? Maybe. But usually those are more diffuse or have other signs like hives. Could it be a hematoma? Or even, theoretically, a compartment-like syndrome in the muscle?
So how do you sort it out?
Well, clinical suspicion is number one. Seeing that localized tender swelling is key. Then, getting specialists involved early is important. In this case, plastic surgery was consulted, which was the right move. Early recognition and expert input are vital when something unexpected pops up.
Any imaging help?
A CT scan can be very helpful, yeah. It can visualize the master muscle directly, show swelling, maybe show changes consistent with necrosis or lack of contrast enhancement, and it helps rule out other things like a bleed or abscess.
So prompt recognition in the PCU or even back in the OR is key.
Absolutely. Vigilance doesn't stop when the surgery ends. Careful post-op assessment is critical.
Okay, so let's try and bring this all together. The take-home message seems to be that master muscle necrosis, while rare, is a real risk.
It is, especially in these long, prone spine cases.
And factors like obesity and, interestingly, the use of MEP monitoring seem to potentially increase that risk.
That appears to be the case, yeah. The combination seems particularly troublesome.
And while it's not directly caused by anesthetic drugs, the anesthesiologist is crucial for prevention, right?
Absolutely vital. Positioning, padding, pressure relief, hemodynamic management. That's all squarely in the anesthesiologist's court. And then being aware of the possibility, watching for it post-op, and helping get the diagnosis rolling if it does happen.
So it really underlines the importance of, well, awareness. Thinking beyond just the drugs in the airway to things like pressure injury, especially in high-risk scenarios. And then considering how our own tools, like MEPs, might interact with those risks.
Couldn't agree more. It's a reminder that everything is connected in patient care. Seemingly unrelated factors, patient position, monitoring techniques, patient physiology, they can all interact.
Yeah.
It really highlights the complexity we deal with and the need for that holistic, vigilant approach from the entire team.
It really does. And it makes you think, doesn't it? How many other sort of subtle interactions might be happening during complex procedures that we need to be aware of? Always something more to consider for optimal patient